their return to society, how they return back to what they do, their social environments, and all of that long term. Thank you, sir.
Yeah. Yeah, thank you very much. That's a brilliant one. Yeah, she talked about, some of the challenges we can face as physio when we come across these patients in terms of phantom pain. She talked about their activity level, returning them back to the environment. These are great things. Thank you very much for that brilliant, brilliant one. Yeah, can I have one more person? Can I have one more
Okay.
person? Yeah, good evening. Yeah.
My name is Yuji. So, one challenge most of these patients has is, especially if it's a younger person, is like accepting reality that this leg is no longer there. So the psychological aspect cannot like be overemphasized because most times they are not compliant with treatment. So a lot of motivational interview has to be done to get the person be like actively involved in what you are doing and believe in what you are doing, so that they will plan the treatment alongside you while you're also managing the other aspects of what led to the amputation and then how to get back to life and his ADLs as well.
Mm.
Thank you.
All right, brilliant. Thank you very much. Perfect stuff. Yeah, yeah. So she, talking about emotional, psychological part of it. Yeah, she mentioned things around CBT, which are really, really brilliant things we can be doing with this patient. One thing I can really phantom from the two speakers is if you look at this patient, this is a big change for them, and we really need to be thinking big for them when it comes to goal settings, when it comes to returning them back to the environment. And believe me, this is not going to be physio again. This is not going to be physio alone. It's going to be the environment. It's going to be even the government. It's going to be the MDT and the family and everybody involved, just to to get this patient population back into normal independence.
So put them in the freezer, in the fridge.
So all right, so let's crack on. So acute limb loss, like I mentioned, I'm going to be I will center this discussion majorly on vascular. So acute limb loss could be anything vascular related. It could be you can find it could be patient presenting with acute limb ischemia, severe, vascular compromise, pain. It could be critical limb threatening ischemia. It could be severe infections. It could be patient with diabetes. Diabetes is a very, very big factor in these things. It could be patient with peripheral arterial disease. It could be trauma. It could be malignancy. Lot of things could actually make somebody lose their limb acutely. Lot of things: cancer, trauma, compressed regional pain syndrome, anything. I know we know all of these things, but I won't dwell too much on that. So we'll move forward. So now, when we talk about lower limb specifically, so we can actually categorize some of these limb loss into two. We can have the major and we can have the minor limb loss. Oh, a lot of background noises today. Please, can we mute our mic, please, so that we can enjoy ourselves, please. We have a lot to cover, please.
Okay, thank you.
My God. Please, can we mute? Is the organizer on the call, please? Can we mute them, please? How many minutes? So, all right, like I was saying, so we can have the major. So anything above the ankle is actually categorized as a major surgery, major harm, and anything below the ankle is actually categorized as the minor. For instance, now somebody, if you have maybe the ankle being disarticulated, there could be sign amputation. If you go below the knee, of course, that's below the knee. That's transtibia. If you go above the knee, that's femoral. That's above knee amputation. You can also go through the knees. You can so if I show you in this picture now, for instance, I know we know all of these things. So if you go through the hip, this hip disarticulation, so like that. But when it comes to prevalence, of course, below knee is quite very rampant compared to above knee and compared to hip disarticulations as well. But if I ask the questions again, this is going to be discussion throughout today because these are things we are quite familiar with. So from physio point of view, when it comes to rehabbing patients with amputations, either vascular related or trauma or related with trauma, for instance. So why do we really need to put into considerations their level of amputations? Why is that so important? What is the relevance of that to us as a physio? Hello? Hello? Can you hear me? Are we still there?
Yes, we can hear you, sir.
Yeah. So my question, because it's going to be discussion throughout, my question is, yeah, I mentioned there can be major, there can be minor. Major is anything above the ankle, and below the ankle is minor. So why are we so interested in the level of amputations? Why is that related to, like, how is that related to us as physio? So what does that mean to us? If you go in to see a patient and they've got above knee amputation, for instance, what does that mean to us? And if they've got below knee amputation, what does that mean to us? Yeah, anyone? Anyone? Yeah, the previous discussion we've had, I'm reading the chat box now. The greatest goal will be to restore the amputee to the highest possible level of independence. Brilliant. Return them their functions, improve their quality of life, save mobility, prosthetic rehabilitations, community reintegration. Perfect, good one. Thank you very much. People also mentioned to prevent contracture. Great job. So I'm coming back to my questions. If somebody have got above knee amputation or they've got below knee amputations, what is the relevance of that to us as physio? Anyone pop your response in the chat box, open your mic, talk to us. Why is that linked to whatever we've been doing with our patients? Who is helping us? All right, let me check the chat box. Yeah, PTUG has written, it probably affect the biomechanics based on the joints paired. Yeah, the residuum, the remaining limbs, we need to be thinking about that. If potentially, if they will be getting prosthetic limb in the long run, so that is going to be affecting the fitting of the leg. It's going to affect that. Then, yeah, that's a brilliant one. Thank you very much for that. Dr. Emmanuel has written, we are interested in level of amputation because it determines the patient functional ability. Great one. Prosthetic options, rehabilitation plan, energy requirement for walking, risk complications, overall outcome. Brilliant, brilliant stuff. Thank you very much for that. Yeah. So these are everything we'll be discussing today. I think Dr. Emmanuel has assisted us because, for instance, now if somebody have got below knee amputations, below knee, so they've got much more muscle residuum compared to somebody that have got above knee amputations. So if you're going to be fitting legs, don't forget you will be adding extra weight to their body. So when it comes to managing mobility, mobilizing or ambulating with that leg, it's going to be energy consuming. So we really need to be thinking about, if this patient is going in the line of prosthetic rehabilitation, so we need to also look into the energy requirement to drive that prosthetic leg, which is very important. Of course, in terms of just like what you are written, in terms of risk complications, somebody have got below knee, you are looking at flexion contracture. If they've got even above knee, you are looking at their hip contracture, hip flexion contracture as well. These are things we need to know as background things as physio. And again, in terms of overall outcome, of course, for somebody to have had above knee in the first place, or somebody have got hip disarticulations in the first place, from vascular point of view, not trauma point of view now, for instance, from vascular point of view, that means that person has really, really got a very, very severe, if it is diabetes, very, very severe. If it is arterial disease, severe one. For somebody to have had that surgery, I hope as that shows that is a very, very severe one. If that makes sense to somebody. For the surgeon to have gone to the hip, disarticulating the hip, and not the knee, not the ankle, that means they've got a really, really. So when it comes to prosthetic rehabilitations, if they will be getting leg, or when it comes to your criteria you are looking at to make decisions with your patients regarding if they will be getting limbs. These are things you are also putting into consideration as well. If that makes sense, yeah. All right. So let's continue. Some other classification you can find, of course, emergency. You can find elective procedure. Elective could be maybe somebody have got diabetic foot ulcer, they've got maybe they've got heel ulcer, they've got plantar ulcer, anything ulcer, or some people they might have had maybe toe hamp in the past, but maybe at some point they've got a very severe wound. I'm going to show you some picture later on. They've got a very severe wound and they start going off. They've got heel ulcer. One of the risk factor, let me say this at this junction, one of the risk factor for a major amputation is heel ulcer. Heel ulcer is a very risk factor. If somebody has got a heel ulcer, so we as physio, we need to really teach them how to take care of that. Have we referred them for prosthetic to orthotics? Have you gotten a good offloading boot for them? Because if you really don't take care of that heel, in the meantime, that heel might deteriorate, and in order to salvage that leg, they might need to go maybe a bit. They might need to do maybe maybe a little bit above the ankle. So in the return, that will turn to below knee amputation, if that makes sense. So so an emergency could be anything. It could be patient, maybe they've got sepsis, they are in the ITU, they've got a really bad infection in their leg. If that leg is not chopped up, it's going to impact them, they can die because of that. So all of these things, even trauma also come into these things. Yeah. All right. So when it comes to acute management pathway, yeah, so we are gradually entering into our physio bit of these things. So if it is not in case of trauma, if it is elective, like, oh yeah, our patient is being prepared, they are on bed, of course, what we want to be doing from physio point of view is we want to be seeing this patient even prior to their surgery. So if we are seeing this patient prior to their surgery, so what kind of discussions do we want to be having with this patient? What kind of discussions? So what are we going there to be assessing? Physios. Can I get a response here? So imagine somebody has been booked down, your patient has been booked down for maybe tomorrow now, they will have been booked down for below knee amputations, and you want to pre-op them. Of course, it's very important because evidences are shown that a lot of patients that are pre-op, of course, a lot of them come out with a good outcome compared to people that are not pre-op. I'm talking of vascular now, not orthopedic. Yeah. So now, if you are going into pre-op your patient, so what kind of conversations or what are we going to be doing with them? What are we assessing with them? So and what do you think in terms of when you'll be going to see them after the surgery? How do you think your pre-op is going to impact your day one assessment with them? Can I get a response? Yeah. Patient is being booked down tomorrow for below knee amputation. They are currently in bed now, and I am the physio that has been assigned to see that patient. I'm going to their bedside. So what kind of conversations or what kind of assessment? How do I assess this patient? How do I pre-op this patient? Can I get our opinion, please? Hello? Hello, are we there? Are we still there, or my network is messing me? Hello, can I get a response, please? All right. Yeah, okay, thank you. Thank you, Tifunka. Yeah, we can hear you.
Hello? Yes, sir, you can unmute. You can unmute, sir.
Oh, I don't know. I'm sorry. I'm sorry. I think it's just I think it's just the network. So I was struggling to unmute myself. Sorry, guys. So like I was saying, because of time, let's just go straight to it. So I was actually asking, somebody has been booked down for below knee amputation tomorrow. So what do we want to be doing with them? Of course, we want to go to their bedside. We want to check if they are even aware of the procedure. I think that should be the first thing, physio wise, because now we are in the health, of course, like we've been saying in some of our sessions, getting patients to be aware, checking your patient awareness of whatever things they are going in for, checking their understanding, their impression about it, checking. We are going to their bedside. You want to be checking their impressions, their understanding of the procedure, what they think is going to happen to them after the procedure, how they think they're going to cope. These are things, because it's not just the physical aspect of it. There are a lot of psychological aspects to these things as well. You also want to check what are their concerns at the moment, what are their greatest worry after the amputations. You will hear a lot of stories. People will tell you about, oh yeah, how how they are likely to struggle going back to their place of work, how they are likely to struggle family-wise, how they are likely to struggle environment-wise. So we need to be checking all of these things, and these are things that also help us when it comes to setting goals, which are realistic goals with our patient. As well, what are their expectations? What are their expectations as well? In terms of expectations, it is normal for people to tell you unrealistic things. And again, it's not, sometimes it could not even be something you want to dismiss. It does not necessarily have to be something you want to challenge immediately. But getting some of these things from your patient really, really go a long way. And aside from that, of course, you want to take a very, very good comprehensive social history. Why do we need social history? You need to understand their baseline, functional wise. Where are they coming from? Are they normally very independent? Are they very active? Somebody that is normally very independent, very active, yeah, they are likely to do well after the surgery. They're likely to be fine with their transfer. They're likely to be fine with their ADLs on wheelchair. They are likely to, to be fine with wheelchair skills. They are likely to go in the pathway, if other things are all other things being equal, they are likely to go in the pathway of getting a prosthetic limb, if that makes sense. You also need to check your social history. Is not just checking their it's not just checking their physical aspect of things. It's also checking where do they live. If you are not completing a social history for somebody going in, especially with this kind of somebody going in with this major procedure, if you are not checking their environmental, if you are not completing your environmental assessment, their home assessment, you have not really done enough for that kind of patient. So you need to ask them questions around their home. What kind of bed do they live in? What kind of house do they live in? Is it house? What kind of property do they live in? Is it house? Is it bungalow? Is it no? Is it have they got stairs at home? Is there any step access to their property? You really need to take a very, very comprehensive social history. In terms of their bed, what kind of bed have they got? Have they got at home? In terms of the height of the bed, sometimes it could be that where I work, for instance, it could be that you give them, you design a form that can, that can include things around the height of their bed, maybe the height of their toilet, because it's going to be a big change for them in terms of bed transfer. in terms of toilet transfer, in terms of if they've got step access to their property, in terms of if they need to be going out, it's going to impact them. So we really need to think about, do we really need form, or do we really need OT, for instance, to go into their property to check some of these things, to see if there is any major adaptations or if there is any minor adaptations that need to be made for this patient group. So things like you have to take social histories, you have to get information around their bed, the height of their bed, you have their toilet, all those kind of things, their bathroom, their shower, their kitchen, step access. So do they live alone? Do they live with somebody? Do they have family members? Is anyone ready to help them after their procedure? So we really need to take all these comprehensive social histories. How about their work? Their work. So we need to think about those things. What is the plan? Going back to their work, we need to ask them some of these things. And aside from that, their baseline of activities, their baseline is also very important in terms of cognition as well. Cognitions, of course, what we also want to be doing beyond social history again is you also have to take their cognitive baseline. Before their procedure, you can do a quick 480 pre-op. When you are pre-oping, then do a quick 480 with them. If they are able, the educational background is also another thing to factor in here because of our country. So you want to take things around, completely things around. Are they able to tell you their date of birth, their age, can they do month of the year backward, all those kind of things, complete good social history, 480 with them. It really goes a long way. And aside from that, some other things you can also check is wheelchair. We need to start having discussion about wheelchair. Not all amputee patients will go in the lane of getting a prosthetic leg. And again, people that will get a prosthetic leg, there are pathways, there are rehab milestones they need to achieve before they finally get a leg. It's not something that suddenly occurs in a day. So how do we, before you finally get a limb, there are pathways you need to track. So before the pathway, so what will you be using? Tentatively, it could be a wheelchair. So it's likely to be a wheelchair. So we need to start having discussion about the wheelchair. Have you got your OT colleagues, or if you are the physios, that is what is obtainable where you work. Have you done the wheelchair measurement? Have you done some of those things? Educations. How do you educate them as well? Pre-warn your patient day one, according to ERAS protocol. After their surgery, they will still see your face again. They will still see you again. If they are medically well after their surgery, you should be getting your patient out of bed. That is the natural, that is the gold standard. They will still see you. Tell them they will still see you after their surgery. And what are you doing with them? You are planning to get them out of bed. You are planning to establish a good transfer method with them. These are some of those things you are discussing with your patient. If they are exercise leaflet, you can also practice some exercises with them, upper limb exercises to strengthen their upper bodies, lower limb exercises, even the transfer, pivot transfer, lateral, low lateral transfer, whatever transfer they may likely, by your assessment, whatever transfer they are likely to be doing, you can also practice those things with them. So take a good comprehensive social histories, pay attention to their past medical histories, to their presenting complaints, their limb issues, their diabetic foot, has it been long? When did they start it? Their past medical histories, do they have comorbidities like COPD? Have they got heart issues? Have they got renal problem? Things that can actually impact them after their surgery, or things that can actually lower their exercise tolerance. So think about those things. And again, so aside from that, review their chest, because they are going in for a major surgery. They are likely to be under anesthetic agent. They are likely to be under anesthetic agent. So after their procedure, some patients may leave the theater and they start standing chesty, and some patients might be fine. So you want to do pre-op, like a baseline, to get their baseline before the surgery, complete a good social history, do a good cognitive assessment, do a good chest review with this then when it comes to your objective assessment, of course, just like every other patient, your range of information, your sensation testing, your strength testing, all of these things are what we want to be doing with our patient. Now, the other thing here is, when you go see this patient group before their surgery, there are likely some questions that might be popping up. There are likely some questions they might be asking you. Question around, when am I going to get a leg? When am I going to get a leg? Suppose you are the physio now, and I'm your patient, and I've mentioned to you and I've asked you this kind of questions. What do you think? So what responses will you be giving to me? You have done your assessment, you have done everything, and the questions I'm asking you is, I'm going to have my procedure tomorrow. So when am I likely to get a leg? So what will be your response? How will you reply me? Yeah, somebody have written in the chat box, pre-op physios include patient education, psychological support, range of motion exercise, respiratory assessment, good. Prepare your patient physically, mentally, reduce postoperative complications, yeah, improve functions and functional. Excellent stuff. Excellent stuff. So pre-warn them, you are coming back, you get them out of bed. They are likely to educate them about phantom pain, about phantom sensations, tongue pain, all of those things. Exercises that you are likely to do with them after the surgery. Comment the exercises before their surgery. If you've got exercise booklet that they can practice on their own, give them the exercise booklet. And again, it's also possible for some patients before their surgery, they are moody, they are struggling with acceptance. Yeah, they've consented for the procedure, but they are still struggling. So what do we want to do? In our facility, have we got those counseling counseling people that can support them? Have we asked their family to talk to them? If they are Muslim, if they people that are really if they are Muslim, have you got religious leader to come and speak with them? And you as physio as well, we are empathetic as well. We are empathetic people. Have we also used some of our skills to educate them? Have we also talked them through when it comes to rehab support, how we can support them, to promote their independence? Have you had those conversations with them? Just for reassurance sake, have you had those conversations with them? So back to my question. Thank you very much for that response. So back to my question. So if I'm your patient and I'm asking you, when am I likely to get a leg? So what will be your response? Is there anything you are checking? Is there any tools, or what are you checking? You've read through my past medical history, you've checked everything, you've looked at me, you've gotten my baseline mobility, cognition, and everything. So what will you be feeding back to me? Yeah. You can pop your response in the chat box. I'm reading the chat box now. Yeah, PTUG has written baseline assessment. Yeah, in terms of what you are checking before the surgery, baseline assessment, assessing his knowledge, awareness of pre-existing conditions going to lead to amputations, giving clarification and additional information. Yeah, sensation, pain, pause. Yeah, great cardiovascular endurance, great stuff. Of course. Yeah, functional assessment rates, ADLs. Yeah, good stuff. Yeah. So what will you be saying to me if I've mentioned to you that I've asked you, I've put that question to you, that when am I likely to get a leg? What will be your response? Sorry, can we hear me? I will stay there because, hello? Hello? Yeah, okay, thank you for that. Yeah, we stay there. Yeah, post-op assessment will determine when they will get the leg. That's what PT, I'm sorry to pronounce that name, but I'll say PT Ibrahim. That's what is written. Yeah, PT Amara in the chat box. Yeah. Oh, we can hear you good. Yeah, thank you for that. PT Antonio, I will tell the patient they will get a leg when the surgery wound is accurately. That's what is written. Thank you for that response. Yeah, can we get more chat? Because these are questions patients are likely to put forward to us. So how do we reply them? So what kind of things should we be saying to them? Or are we just going to be dismissive and tell them, see, just focus on your surgery tomorrow, forget about that for now? Are there something you want to check, or any assessment tools you want to complete with them that can give you a clue? Or is there anything you have looked at their record and everything? Is there anything that can say, yeah, this person is likely to go? in the lane of getting a leg, or this person is not, it is highly unlikely that you're going to get a leg. Yeah, PT, Kelechi has written, it depends on the cost of amputation, the rate of healing expected. Good job. Yeah, good stuff. Great stuff. So because you don't want to give foxhole for your patient, and again, you don't want to make a predictions make a wrong prediction again. So you want to be, and at the same time, your patient needs your professional advice here, and your professional response. All right. So without wasting time, there is an assessment tool. Actually, we are meant to be completing with this patient group before their surgery, or if you are seeing them after the surgery as well, you can still complete it. It is called Black Score. I'm going to still show us, but I just want you guys to get aware of that. It's called Black Score. So on the Black Score, even without the Black Score, it's something we can clinically reason together as well. What are those criteria? What are those things I can put into considerations to predict if this patient will go in the line of getting a leg? We want to think about things like, look at their comorbidities, look at their past medical histories. You see somebody with, chronic COPD patient, not a chronic COPD patient. Anyway, let's say chronic COPD patient, and by the time you correlate that with their baseline, they're just bedbound. They are not what they do on their day-to-day life before the amputations, before they start having issues with amputation and all, is they are all care in bed. They just do transfer from bed to chair. Or you can still have somebody that is they've got chronic COPD, but they are normally very active. They can go to other, that's fine. So think about that. Think about, somebody with heart conditions. It does not still mean again, when you are looking at the past medical history, it does not still mean again that all heart condition patients cannot go in the line of not getting a leg. Correlate that with where they are coming from, with their mobility, with their function and everything. Oh, if this heart condition patient, by the time they walk 2, 3 meters, 5 meters, 7 meters, they are really, really short of breath. They are really fatigued. They are struggling to catch their breath. Think about that. Or if you've got this renal patient with poor exercise tolerance normally, few distance, they are very fatigued. So if we are thinking prior to having issues with their leg, so if you are now thinking by the time they now get the leg removed and you now give them a prosthetic, the energy requirement to drive that prosthetic might really, really be very high. So they might not be able to get it. You want to start having those thinking in your head. These are things you'll find on the Black Score, things around their comorbidity. You find, they've got this severe, very, very bad stroke on the other side. They've got hemiparetic side. There's no strength, there's no anything. Now they want to remove the good leg. What is the chance of that person going in that lane? I understand these are very, very difficult conversations, but these are conversations we need to really, really be very prepared. And sometimes, let me say this as well, because of maybe for the surgeon, in the course of getting your patient to do the surgery, because the surgeon understands the only thing that can salvage this patient's life is to chop up this leg. So sometimes they can give them stuff. First of all, I will refer you, I will get the physio involved. They can work you out. They can work prosthetic leg. In a patient that has got hemiparetic leg, very dense stroke, no strength, no sensation, nothing. So we want to go to the bedside to change some of this rationale. It's going to be a very, very difficult conversation with them. But we need to first understand our onions. This is our domain. And again, what do you want to speak back to the surgeon? Sometimes some people do. It might be because lack of some knowledge about some certain things. It's not something we want to go back to them and start fighting them. It could be just something you want to also educate them as well. Why not leaving that part, that rehabilitation part to physios? Why not leaving that to physios? So why not having your discussion, getting your patient to do this surgical procedure without needing to bring in rehabilitation part? This should not be a fight. This should just be normal human to human relation. All right, you'll find things like their comorbidity, like I mentioned. Pay attention to it, scrutinize it, link their comorbidity to their function. Don't just look at their comorbidity and say, they've got stroke. They've got stroke 2 years ago, but they are doing fine. They can still get a leg. But if they got stroke, but really, really bad stroke, that will actually impact on their mobility, in their balance, in their endurance, link fatigue level, link those things. That's how you think as physio. Think about that. What other things do you find? You find things like the level of the amputations, the level of amputations. What do you find on the level? Like we have mentioned, if somebody is going in for below knee amputation, for instance, they are likely, they've got a chance to get a prosthetic leg. Their scoring on that blast score is going to be, it's going to be lower than somebody going in for hip disarticulations or above knee amputation, for instance, because they've got, when it comes to the residual mass now, it is much more, compared to somebody going in for hip disarticulation. So if you want to fit a leg, it will be much more easy from biomechanics point of view. It's much more easy to drive and to fit below knee amputation as opposed to above knee, even as opposed to hip disarticulation. If that makes sense, you start thinking in that way. Oh yeah, you are going in for below. Or how about if somebody is going in for bilateral below, above knee amputation? That further put them down. Like that further narrows their chance of getting a leg. All this thing comes with score. If I'm making sense. How about, think about it. How about, I'm just trying to make different scenario, and I really want to spend few time here to explain some of these things, because these are what we see day to day in our work, if you cover vascular ward, and these are very, very difficult conversations, and you really need to get things right. So think about those things. Think about the level of amputations. Think about, is it unilateral? Is it bilateral? What is the contralateral limb, the other leg, the contralateral leg? What is the situation at the moment? Sometimes in some people, you might find maybe one of their toes is being chopped up, or you can even find, by the time you look at their foot on the plantar surface, you can find ulcer, heel ulcer. The chance is also there for them that the other leg in the long run can also, don't forget this is vascular we are dealing with. The other leg in the long run can also be chopped up. What is their chance? Their chance for that goes down. Think about some of these things. If that makes sense. Then again, of course, I've talked about their comorbidities. I've talked about their previous level of functions. And again, some other things also need to put into consideration is after the procedure, when you when you commence your rehabilitations with them, you also want to tell your patient that some other things you factor in is how they are doing, their current ability after their procedure. Are they fine with their wheelchair transfer? Are they able to do it? Are they fine with their wheelchair skills? Are they able to do push-up? What is their independence with the wheelchair? These are things you need to factor in. Somebody struggling with transfer, somebody that cannot even do pivoting transfer from bed to chair, and you start thinking about getting limp. It might be challenging to them. Think about all of these things. All right, let's crack on. We'll still come back to the blood score, but these are some of those things we need to consider. Think about their BMI. Think of a lot of things to consider. So I'm just trying to open it up so we can have different technical reasons when it comes to having these conversations with our patients. Some other things we can also consider. You might find patients struggling with acceptance to have the procedure, and they're asking you these questions. So we really need to be empathetic and think about how am I going to pass this information to them without getting them hurt, without adding to their problem. And remember, whatever you tell them pre-op, whatever, like their impression their impression of you pre-op is going to impact them post-op. Think about all of these things. Think about all of these things. So if your patient are, so part of what I really like us to complete before the amputation is complete blood score. I will still show us blood score, complete blood score with them. And if there are questions around, would I get it? So you want to also explain some of these criteria to them. Oh, your past medical history is this, your previous level of function is this, but again, we also check after your surgery how you are doing, all of these things. So it might be difficult for you to say yes, they will get it. No, they will not get it. But find a way to sit on the fence. Find a way to sit on. That's what, because it's always a very, very difficult conversation. If that makes sense. Please, is somebody here? Is it making sense, or am I just talking to myself or something? I'm really taking my time here. Yeah. Functional level, first of all, it depends before listing the factor. Okay. Yeah. Is it making sense, guys? Are we getting this thing? Yeah. Yeah, it's making sense. Thank you, everyone. Yeah, thank you. Yeah, yeah, yeah. Thank you. Yeah, did you say Blatt score? Blatt, B-L-A-R-T. Yeah, B-L-A-R-T. Yeah, that's it. Thank you. It's making sense. Thank you very much for that. So let's continue. So, of course, your subjective assessment, fall history is another thing. Somebody that will be having their leg being chopped up, they are at high risk of fall. These are things you need to start educating. And again, it's something somebody can pick it up in our various places of work. Like if you see, like maybe where you work, you are into, patient with like you see a lot of amputees and everything. We can have service development. Somebody can develop something, maybe exercises, pre-op exercises for amputee patient, post-op exercises, what we want to be doing with them. Their peer pack, if you check online, you're going to find a lot of these things. So fall, you can find things about fall. If your patient is, maybe they're educated, you can have a booklet that will give to them prior to their surgery. When we do all of these things, it further solidifies our role, in the MDT. It further solidifies, even in the mind of patients, it further shows how empathetic and how compassionate we are. So it's something somebody can pick up. Let's have service development for booklets and for booklet, exercise booklet, all of these things. All right. So home situation, like I mentioned, it is something, and again, we can design a form for them, checking the height of their bed, somebody can give it to their family member, they can take it home. Our rehabs to focus on ADH. They can take it home, give us the height of their bed. Even in the hospital, if we need to start practicing transfer with them, we want to practice transfer with the same height of their bed. How about toilet? Normal toilet, 16 inches. Normal toilet. Now, if somebody needs to transfer from the wheelchair to the chair, the height of wheelchair should be around 18 inches or thereabout. If you need to transfer, that is height indifference. We need to practice all of these things with our patients. So the OTs, these are domains of OT aspect. This is domain, rehabilitation domain. So our OT, they might go to their home, or if they can't do that, we can give them booklet, family members. If they've got step to their property, we can ask them to measure the height of the step for us to see their standard. These are some of the OT stuff. Their standard, for instance, if you want to, their removable ramp, patient can buy online, family member can buy for them. But from safety point of view, for instance, now, if the height of the step is more than 10 inches, for instance, you don't want to ask them to get ramp, like to get removable ramp. It might be from safety point of view, might be very, very dangerous for your patient. These are some OT stuff, OT domain that we really need to be doing, because this is a big change for our patients. But if the ramp, let's say for the height of the step now is more than 10, you want to maybe advise on major adaptations, maybe get bricklayer to do some work, something like that. So let's begin to think about because it's a big change. All right, because of time, let's crack on. All right, oh my God, this is not showing well. Sorry, it's upside down. So this is the blast score. So I will send this, I will make it properly. I will send this slide to us so we can explore this, we can integrate this into our practice. I think if the score is less than, I think 13, something like that. If the score is less than 13, there is 85% chance that your patient is likely to get a leg, that the patient, they are likely to walk with or without prosthetic, like with prosthetic leg, with or without equipment. They are likely to walk. With equipment, either with elbow crutches, with frame or something, with or without equipment, the chance is there. The score is less than 30. So if somebody is scoring maybe 14 to 21, yeah, they've also got a chance, but lesser chance compared to 30. And if the score is greater than 21, 22, something like that, no, the chance is very poor. It is very unlikely that they may not get a leg. Like they may not do well with the leg. We can begin to use some of these things to our practice, just to make predictions. This is not absolute. Don't forget your clinical reasonings or everything still come into these things. Look at their comorbidities, look at their current function, look at their age again, look at their goals. What is your patient motivation? And again, when it comes to leg or no leg, you also want to factor in what your patient wants, what they want as well. You also want to talk them through what is their goal, what are their expectations. Some people, they don't really, but I have met, even before leaving Nigeria, I have met patients, they don't really care. They just want to be in the wheelchair for the rest of their life. That's fine. That's their wish. If we are, even if they meet the criteria, they are doing well with transfer and everything. Yeah, if that is what they want, that's okay. That's okay for them. So think about some of these things before we start having those discussions with our patient. All right, let's go. Let's move forward. Day one now. What do you want to start doing with your patient? I will explain this, but if you think about anything, pop it in the chat box. This is just a discussion, anyways. So day one post-op, what do we start want to think? Of course, day one, you are going to their bedside. Of course, you want to check, you want to ask them, compassionate. You want to ask them, the surgery, how did it go? How did it go? Ask them those questions. Ask them about their pain. Of course, you know they will definitely be in pain. Somebody have had a major amputation. Their legs they just chopped up their leg. They are likely going to be in pain. Ask them question about pain. And we still come back to pain. Pain could be storm pain, it could be phantom pain, or we are still coming back to those. Ask them about pain. Rate their pain. What do you want to say to them regarding their pain? How do you want to manage their pain? Have they had any pain medication before you come around? Do you want to liaise with the nursing staff for appropriate PRN pain medications? They're going to be in pain. What do you want to do? Some people might be in PCA. Of course, I've shown you that in the previous sessions. Do you want to ask them to press that? Press that PCA? And if the pain is suboptimal, with the pain, they feel like they are just in pain, they are groaning in pain. What do you want to do? And you know from physio point of view, if somebody is groaning in pain, they are not even paying attention, you are not going to get anything out of that patient. And again, compassion. Oftentimes, based on who we are, oftentimes, when we see this patient, or even you can find the nurses shouting on them, oh, is it you just have pain medication, we are giving you this, why is it? No, these are pain has different layers, and the threshold of pain varies from person to person. These are what we need to be educating ourselves. We need to be empathetic, compassionate. If they are saying they are in pain, if you just done something, you just give them pain medication, that does not warrant you shouting on your patient or screaming on them. It does not make sense. All right. So these are healthy behaviors we want to show to our patients. We want to show from human to human relation point of view. So, and as a good professional, being empathetic is also part of our job. All right, beyond pain, what else? Oh yeah, their pain is fine. Where you've assessed their pain, all these things. What else? Do you want to reassess their cognition? Don't forget you've done that part with their surgery. Do another quick 480 now. Do you have good reasons to check their 480? What are the reasons? Now they've had major procedure. Some of them might be sedated, they might be sedated, they might be on anesthetic agent prior to that procedure. All of these things are likely to make people confused. And again, some of them, some people's surgery might last as long as 4 hours, 6 hours. Somebody lying on surgical table 4 hours, 6 hours, not eating, not drinking. What happens? Dehydration can make them confused. Pain now they are having post-op pain. Pain can make them to be confused. The medication they're having to control everything can make them to be confused. Anesthetic agent can make them to be confused. Think about all of these things. Acceptance, everything, emotions, all these things. Think about these things. So you have good reason to do a 480 with them, or do normal orientations. It could be in your dialect, depending on your patient group. Do those things. Assess what they are, or assess the level where they are. After that, do a quick chest review. Do a quick chest review with them. Review their chest. Ask them to take in deep breath. It might not really be you plugging tight on their chest. It could be just you asking them to take in deep breath and cough. Their cough strength, that's enough. Ask them. Have they been coughing and have they been taking in deep breath and cough? Now, begin your assessment. Holistic assessment. Check their acceptance. Check their acceptance. Check their acceptance. It's really very important. The acceptance. So think about those things. And again, your objective assessment, of course, you're still going to repeat your range of motion, your strength, your sensation, all those physio things. You're still going to repeat that again. Now, what other thing do you check? You look at their stone. Is it clean? Or sometimes you might find from if you are seeing them day one after the surgery, you can find what do you call it? Removable dressing from the theater. You can find it on their stone. Document those things. Those things should enter into your note. Those things should go into your note. Your presentation of the patient, they are going in. All those things should go into your note. All right. So what other thing are you checking? You are looking at the storm. You are checking for edema. You are checking for redness. You are checking for discharge. You are checking all of those things. And what do you do after that? Day one, to commence your rehabilitation with them. What are you thinking about? Yeah, if they are able, and again, before you come to their bedside, we have said this thing a lot of time. Check their medical note. Check their postoperative note. Look at their instruction being written there. Look at their blood, your lab. We have had discussion about blood and lab. Have you checked the lab? Have you looked at their HB? This is somebody with major procedure. They might have lost good numbers of blood in the operation room. Some people, after day one, they might even be having blood transfusion. Think about those things. And some people, again, look at their pre-op blood and look at their post-op blood. Anything HB is greater than 80, I'm fine. I can rehab my patient, no challenge. Have you checked their potassium level? Have you checked their INR? Have you checked their platelets? Think about all of these things. We have had discussion about blood. Check their blood. Look at their vitals. Look at their hubs. What is their artery? What is their blood pressure? What is their oxygen level? And they currently, you may find people day one poster, they might be on 2 liters, 3 liters. Nasal spec. Some might be on venturi mask. Think about, check all of these things, document them. We know what we are doing. We have had discussion in the past about these things. So check all of those things. So what else? If your patient is able, commence your rehabilitation. So now, in terms of rehab, how do I commence? Let's have conversation here, guys. So let's have conversations. So day one, what am I thinking? Like, what do you think I should be doing with this patient group? What do you think I should be doing with them? What kind of things can I be doing with them? Can we pop those responses in the chat box, or if you're able to open your mic, you can open and speak to us. Hello? So day one, what will you be doing? Do you want to keep them in bed? Do you want to start doing some gentle exercises, or what is your plan? You're going to their bedside. What is your plan? What ideally, what should you be aiming at day one post-op this patient? What should be your major aim? If they are able to do it, perfect, good. But if they can't do it, we can begin to think about, yeah, let's modify this thing, let's do this, let's do that. What should we be aiming at day one post-op? Are we there, please? I'm sorry, I'm looking disorganized today. It's really warm here. Yeah, all right. So, yeah, somebody has particularly has written proper positioning day one. Yeah, good stuff. Good stuff, proper positioning. Good. Yeah. What should we be aiming at day one post-op? What should be your major goal? Let me put it like that. What should be your major goal? You should be thinking with this patient as per evidence-based practice. Evidence-based. What should be your major goal with this patient? Day one post-op. Yeah. Yeah. PT Ibrahim again. I'm sorry with that first name. Yeah, PT Ibrahim. Let me check. Prospective fitting in addition to those in the slide. Okay, good stuff. Yeah, early mobilization in line with NICE guidelines. This should be UK stuff. Yeah, PT Khalifa, good stuff. Thank you very much. NICE guideline. Good. Yeah, these are some of those things we need in Nigeria, like amputees. If you're in UK, you'll find BACPA guidelines, BACPA. You'll find people in Scotland, they've got, yeah, we need some of these things, guidelines. What we want to be doing with them day one, day two. What is the milestone? What are we aiming at? All these things are not just physio in Oshobo is doing its own differently. Physio in Ogun State is doing, or physio in Kano State. No, we want unify something, unify. So that if I'm referring, for instance, my patient is relocating from Oshobo to Lagos, for instance, or from Delta State to anywhere in the nation, we can easily follow through. We can easily look at what they've done. Patient can easily feed us. We know where to commence our rehabilitation. We need standard things. Yeah, people are writing a lot of stuff. They've written it down. Yeah, PT Khalifa, thank you for your response. Yeah, day one positioning to prevent edema. That's PT Ezugu. Yeah, thank you very much. PT Temitope, proper positioning in bed, great stuff. PT Huji, reassurance, reduce pain, prevent weakness, positioning, isometric exercises. These are all good stuff, brilliant stuff. Keep popping your response. Yeah. But let me say this. Your goal, day one, if your patient is able, should be commence established transfer method with your patient. Don't forget, this is an acute hospital. Don't forget, we are here. This is acute hospital. Remember, what we've been doing is acute rehabilitations. Remember, your patient have got short lifespan with you in the hospital. Yeah, great stuff. Position them in bed. Start talking about prosthesis. Yeah, prosthetic leg. Yeah, those things. Yeah, great stuff. But your major goal is establish transfer method with your patient day one. Think about that. So what do I want to do day one? I want to get them up. Get them to see. First of all, get them to sit at the edge of bed, first of all. Sit them at the edge of bed. Sit them, edge of bed. Look at their balance. Because somebody normally has 2 legs. Now he's having 1 leg. Check their balance at the edge of bed. Why are you checking their balance? You have reason to that. And those reasons will go into your note as well. How are they presented? Now, how do you mobilize them from supine positioning to edge of bed? Do they need to? You will normally find patients struggling. In fact, by standard, the recommendation is day one. If you are going to their bedside, it should be joint sections, either PTOT, physios and OT. If you've not got OT in your facility, that's fine. Then go with 2 physios. Or if it is an OT, 2 OTs, that's fine. Go to their bedside. Get them up. Get them to see edge of bed day one. And how did you get them? What is this you go into your note? Oh, assistance of 2 to mobilize them from lying down to sitting edge of bed. And again, put all this thing in your note. Are they able to initiate the movement? Are they able? These are practical things. I'm struggling to explain better, but these are practical things. Now they are at the edge of bed. What else do you assess? You assess for their balance. Some people might be falling sideways, they might be retropulsive, they might be falling backward, they might be falling forward because they've got 1 leg now. Why? Because it could be from struggling with midline alignment. It could be proprioceptions. It could be sensory changes. It could be cortical reorganizations, brain issues. Check their balance. Check their balance. Some people, yeah, you get them up from line to sitting. Some people they are gallant. Some people are able to maintain their static balance. Check their dynamic balance. Do some reaching. Rehabilitation is very sweet. Do some reaching sideways. Let them reach up. Let them reach down. Let them touch their toes. Assess their dynamic balance. Check those things. So now you've checked their balance. Of course, if you've got somebody struggling with sitting balance, static sitting balance, what do you want to do? Of course, get them to fix on their upper limb, supported sitting, do whatever you want to do with them to progress. Of course, part of what you can also do to progress their sitting balance, if somebody is struggling, either proprioception, whatever, cortical issues, anything, what do you want to do? Do some reaching, sideways, upwards, all those things. Get them to flex their trunk, get them to extend their trunk. Or these are some exercises you can do to progress them. Somebody can stand in the front, ask them to align themselves with we know some of these things to progress their sitting balance. After that, if they are able, from the sitting balance, commence your transfer to the wheelchair. Now, let me say this. I'm still going to talk about this thing later on if we have the time in this presentation. Lot of questions people will ask is, can I stand when with frame? Even patient will ask, oh, can you get me crutches? Let me try to stand. Believe me, I know in our practice, a lot of us, we have done these things in the past, but these are not evidence-based. No crutches, no standing, no frame, no standing aid for a patient with vascular amputations. There are reasons for this. I would still discuss. There are reasons for this. There are reasons for that. Believe me, for now, I'll give you the reason later on. By the time I get there, there is no standing, no frame, no walking stick or whatever equipment, standing aid you want to give them. It is not by standard. Go standard. Any standard. All of these equipment, standing aids are not generally recommended. So what you are thinking about is, of course, if they've not got wheelchair, family they are still raising money for it based on our situation. Go with your own department wheelchair. Go with your commence transfer. What kind of transfer? Oh, some people, depending on their pre-op functional level, some people might need to do banana board transfer, slide board transfer. These are transfer method. Some people might be needing some people might still be able to do low lateral transfer. Some people might pivoting, or if they are unable to do any of these things, how about what other aids do you use? Okay, if I ask you guys, what do you think? I want to. We've mentioned today that no standing aid, no frame, no crutches, no no rotunda, no Sarah steady. So how do I get this patient out of bed? And they are strong. Now they can maintain good sitting balance. And my goal is to get them to sit in the wheelchair. And they are unable to get to the wheelchair. So how do I support them to get to the wheelchair? Or let's say they cannot even maintain sitting balance. They are in less pain, no concern with. There are a lot of patients. I've met a lot of patients in that way. But let's say I am not even able to, every other thing is fine. But my goal is, what I'm aiming at is getting them to sit in the wheelchair. But they can't manage any of those transfer methods. What else can I use with this patient to get them to the wheelchair? Can I get response in the chat box, please? Yeah. Can I get response in the chat box? Yeah, breathing exercises, of course, these are part of what we are doing with them day one, from sitting to standing, if okay, if balance is okay, yeah, but I won't recommend standing because what the guideline says, national, what evidences are shown, and what the guideline says is standing is not generally recommended. It's not for vascular patients. It's not something you want to go to their bedside with frame, with crutches, with testing. It's not recommended. Keep it transfer only until if they are able to get leg, prosthetic leg, now they can commence standing, if that makes sense. Everything we are teaching here is standard, what we should be doing, what evidence says. Yeah, perhaps now my question, we can't get them, they can't manage those transfer, they can't manage pivot transfer, they can't manage what is it again? Lateral transfer, they can't manage banana board transfer. What other options can I explore to get them to the wheelchair? We are physios, so we should be thinking for our patient. So perhaps we bring the wheelchair closer, lock it to prevent them from falling. If they place their hand on it. Yeah, good stuff. Thank you, Peter Ibrahim. Yeah. However, if this patient cannot manage this, you have placed the wheelchair close to the chair and close to their bed. You've tried pivot, they are unable to clear their bum, they're able to clear their bottom, their gluteal region. You've tried banana board, they're able to manage with the side seat, they are unable to manage this. What else do we try? We just, yeah. If some people might find it, okay, that's fine, we've done something today, let's return them back to bed. But day 2, day 3, am I still going to keep them in bed? Don't forget what evidence says. If your patient is well enough, remove other factors, they are well enough, they are not struggling with acceptance, they are not struggling with pain concern, no cognitive issues, remove every other factor, we should be getting them out of bed day 1 post. What other thing do I do with them? Okay, offer assistance as PT and withdraw the degree of support. Yeah, that's a great one. But what I'm asking now is, we can't get them to the chair. We are struggling to get them to the chair now, to the wheelchair now. So how do I get them? Do we go with our normal method, 2-person lift? Believe me, this is 2026, and we need to keep showing ourselves that we are not manual laborers. We should be I think in the past, when I was talking about manual handlings, yeah, I have mentioned manual lifting patient, pulling patient, pushing. These are something that in the West, for instance, it can actually cost somebody his or her own license. These are not allowed. And in Nigeria as well, and unfortunately, some of our lecturers, even in school, yeah, we are still teaching all these things without even teaching what the recent, like what matches the recent age. Yeah, somebody can argue that, yeah, those things can be used in maybe remote area where those methods can be used where we've not got. How about in the cities where we've got everything? We've got everything. Yeah. Why are we not teaching? Why are we not teaching the standard? This is 2026. Somebody cannot tell me that in Nigeria now we cannot buy. How much is waste in Nigeria? So you can try that. You are unable to get the. However, have you hoisted them out? Have you hoisted them to the wheelchair? That's another thing you can try with them. That's another thing you can try with them. All right, that's it. Thank you, PTs. Yeah, I love those responses. Yeah, you can hoist them to chair. And even when it comes to your sling too, how you gonna place your sling and everything, it might be quite different from people with patients with 2 legs. Maybe I'm going to show you some pictures later on, but let's crack on because of time. So what have I mentioned here? Day one, what you should be aiming at is getting your patient to sit in the wheelchair. If now you now want to think about it, oh, my patient is they are struggling with pain, I just break the go down. Oh, okay, yeah. Let's try to sit edge of bed today just to manage your pain and everything. Or they are struggling with acceptance. Good. Some people can manage. And when they are sitting at the edge of bed, check those things we have mentioned. Now, if they are unable to do that, you can say, okay, yeah, then you need to maybe shift backward a bit. Oh, let's do some exercises in bed. Oh, move your stump. Of course, it's very safe. They want to start asking patients to start moving their stump, range of motion. And get them to do it actively. It might be very, guiding and guarding and everything. You touching it, yeah. And again, let's say a patient is struggling with pain, for instance. Now, discuss desensitizations with them. What do we mean by desensitizations? Desensitization is getting your patient to be looking at their stump. In fact, what I normally say to some of my patients, if I'm in vascular ward, is, oh, this is like a new baby. We all know the way we care for new baby. Get them to look at it, get them to patch the new baby, get them to touch, get them to light touch, do some light touching, tapping, all those kind of things, just for desensitizations. Because that region day one post-op is likely to be really, really hypersensitive. Do you now want to tell them not to touch, just leave it, ignore it? No, it's your newborn baby. So look at it, touch it, light touch. And again, in some centers, you can find desensitizations kits. You can find different things there. Yeah, you can find maybe cotton wood. You can find something like maybe towels. You can find something like any sort of balls, everything. We can use those things. These are something we can prepare. If your center, your amputee region, you can prepare those things as a kit. You go to their bedside day one with that kit. Get your patient to do it actively. You can do it for them, but promote active things. Get your patient to do things first. But if they are struggling, then you can let me do this for you. Let's do these things together. All these things for desensitization. And now, what that desensitization does, it's going to help with their pain. It's going to help with their pain, and it's going to help with hypersensitivity and everything around it. Does that make sense? Now, all right, edema is also another thing. I'm going to still touch on these things later on. So let's just go on. So day one, if you can't get them out of bed, do edge of bed sitting. If they can't do edge of bed sitting, do bed exercises and again, and tell them to crack on those things you have done with them, if that makes sense. Let's continue. All right. So milestones. So when it comes to milestones now, I won't dwell too much on this because of time. So this is just like a framework, just like a guide. Yeah, let's say, for instance, now your patient is like critically, this patient is likely to get a leg. So we can be thinking just like a rough guide. Maybe day 5, we can try strinkers, day 7, paper mate, day 21, something like that. But I won't sit down with this because I have some important area to touch. I won't sit down with this to start analyzing this, but this is just like a rough guide. And again, if we have the time, we can still come back here, spend plenty of time here and explain some of these things to you. But let's move forward now because of time. So, all right, emotional support. This is another great thing. When you go to see this patient at bedside, emotional support. A lot of people will struggle with acceptance. They will struggle, a lot of them will be faced because of the amputation they've had. A lot of them will struggle to cope. So a lot of them will, a lot of things will be going in on their head. This is a big change. So what do we want to do? Yeah, and again, you can also find patients. Maybe they'll be struggling with chronic pain because of the very arterial disease they've got, or because of the wounds they've got in the long run, and they've dealt with it. They've fight everything. They've fought everything. The pain is still very, and now they've had the leg chop off. I have met some very motivated patients, and their leg is just, they'll be like, wow, it's gone now. Now I'm feel very, very positive. More than even what you clinician, what you expect from them. That's great. We all love to see that kind of patient, right? Yeah, because that motivation is going to impact on their rehab, right? We love them, but that is not always the case. And again, so here you want to start talk your patient through rehab. And again, you can find patients that are just They are not too sad. They are just sitting in the middle. Those kind of patients, you want to have that rehab discussion around rehab wave. I call it rehab wave. Then the wave. You want to have that discussion with them. That means at any point, things might, there might be a lot of highs, there might be sometimes low, but things like that. So what conversation do you want to have with them? Discuss coping strategies. You can have their family to have input in these things, and not just physio. Sometimes you can really have patients that are just down there. They are just feeling that's the end of them. Do you want to involve psychologists to come down to speak with them, to explore some skills? MI is there, to explore some skills to get them motivated. Think about those things. What do you need? It could be pastors, it could be affairs, it could be religious leaders, it could be anyone to come down to speak them based on their faith and based on what we think is going to be your patient is open to. Think about those things. All right. So think about who you can use to support them. And again, if you are the junior physio here, if you are stuck, it could be you reaching out to your senior colleague, to your HOD, to anyone that you feel like, yeah, this person can really help them. We need to be very, very compassionate. All right. So the other thing here is some of the other assessments you need to be doing with your patient is looking at their contralateral leg. Like I mentioned the other time, you can find patients with wound ulcers, or you can also see some patients they've done major amputation, above knee amputation, below knee amputation, and on the other side, they've also chopped some of their toes on the other side. So do you just ignore the other side as well? Do you just ignore that new amputated area? Do you just ignore that? You don't do that. So what do you want to think about? Because you also need to protect that toe amputation. You also need to protect it. So how do you protect that? So we need to have discussion about offloading boots. These are some of them have popped here. Offloading boot wears. This is Veco Casso, Veco Passo. This is Veco Cast. This is Prafo. So if somebody have got heel or side, you are thinking about Prafo. I'm going to discuss that later in this discussion. I won't go into that lane right now. These are offloading boots, offloading footwear. And again, if you've got good orthotics in your department, they want to also ask them to go in to review the patient leg, if they can give some offloading boots just to shift the weight. By the time they start putting weight on that toe amputations, on that foot with toe amputations, the weight of that leg can be redistributed from that new amputation to the other. Or if you've got somebody with if you've got somebody with ulcer, with heel ulcer, like I mentioned, be careful with heel ulcer. If you've got a patient with heel ulcer, the patient is likely to lose the whole leg if care is not taken. What do you want to do? You want to start offloading boots. Look, evidence-based. What does evidence recommend? Get offloading boot for them. Discuss those things with them. I know from point of cost and everything is not very easy for us in Nigeria, but this do we as physio, do we even know in the first place that this thing exists? Great question mark. Big question mark. Do we even know that some of these things exist? That's from our own part. Let's think about these things. So considerations, look at your patient foot. Beyond wounds, beyond amputations, look at their foot. What is the color? Is it swollen? Have they got sense? Don't forget, somebody that have above knee, below knee, their issue in the first place might even be diabetic neuropathy or peripheral arterial disease. So that might also impact on the good leg. Have you checked their sensations? And again, if they've got good sensations, you're not going to feel their leg. It's going to impact their transfer method. Think about those things. So look for colors, temperature. Is it cold? Is it warm? If it is too cold than warm, normal, what do you want to do? Speak with the vascular team, the vascular doctor. I'm worried about this. I think these are clinical reasoning kind of things, if that makes sense. All right, because of time. So now hoping, this is also part of the question patient will ask you, day 1, day 2, or even before surgery. Oh yeah, I think can I buy, or even physios, some of us, even before the surgery, we have started arranging frame for them. But what does evidence say around the OP? Like I mentioned, for vascular patients, let me first check, please. Are we still here, please? I don't want to, because I feel this thing is really, really very important to us, please. Are we still here, please? Are we still
Yes,
here?
sir. Yes,
All
sir.
right. All right. Thank you very much. Thank you very much. Thank you. Thank you. Thank you. Lot of response. Thank you. Thank you very much. Appreciate it. Appreciate it. So now, for vascular patient, like I mentioned, we need to be doing what we need to be doing for our patient. Like, we are professionals, evidence-based. There is no justification for any of us to be doing what is archaic or what is very, very wrong for our patient. And that is why myself, I always say it and I will say it again. In schools, everyone is being taught with what is written in textbooks. And how are we sure that those things that are written in some of those textbooks are not archaic? They are not in line with what new evidences are saying. So that is why we need guidelines and evidences in our country. We all can always, well, we all say that evidence-based, but are we really into it? Vascular patients, no crutches, no frame, no open. No standing aid, no Sarah steady, no rotunda. Why? Why? The reason is this. Imagine for somebody to have lost the right leg below knee, or somebody to have had above knee in the first place. If diabetes is their problem, then it must be a very, very deadly diabetes, if I'm making sense. If what is it? If arterial disease is their problem, it must be a very, sorry for that word, it must be a very, very deadly arterial disease for them to have lost that leg, if that makes sense. Now, so if somebody have lost their leg because of very, very strong disease, and now we gave them frame, and they are now open on the other good leg, 75% evidences have shown that they are likely to lose that leg also. They are likely to end up getting that other leg, that strong leg, being amputated also. That's one. Now, look at the risk. Somebody with diabetes, peripheral neuropathy, all those blah, blah, blah issues, sensation problem, motor problem, you want them to be hoping? How about the risk? Have you looked into the risk of falling? The risk of falling is really, most of them end up coming back to orthopedic world. Orthopedic, oh, they've now fractured their hip. They've now fractured their stump. They've now fractured their femur. So let's think about these things. Vascular patient again. You are getting them to stand. You are getting them to do some hopping around. Think about these things. Some of them are even on the other leg. Some of them might even have ulcer. Maybe dry ulcer now. Fry. We call it fry. Fry one. Before you know, when they start opening on it, what happens? It becomes wet. The wound break down. And before you know, and again, this is we have not even provided good offloading boot for them in the first place. Before you know what happens, they might likely, the wound will start spreading and they might likely end up losing that leg. How about edema? For vascular patients, if you are getting them to hop around and everything. Now, think about it. Gravity will make it easy for fluid to flow down. So at the end of their storm, you likely going to have fluid retention. What will that do? It's going to impact on their healings of that storm. Think about all of these things. Think about all of these things. So for vascular patients, open, frame, crutches, anyone you see that are doing that, they are doing the archaic things, and it's very, very detrimental for that patient. It's not evidence-based. That's it. But for trauma patient, oh, now they lost their leg because they have road traffic accident. Yeah, for trauma patient. If the other leg is fine, look at the ankle, there is no fracture, there is no everything, and they've not got diabetes, they've not got peripheral arterial disease, they've got good balance, a young guy, very active individual, they've got good strength, great. They can still hope, you can still give them frame. That is why I didn't want to mix these two things together. I want to do vascular first, and then we'll come back to discuss if that makes sense to somebody. But right now, just a tip. Just something slight about orthopedics. Yeah, you can still get them to hope. Even with that hoping around, factor in a lot of things. Like look at their past medical histories, clinical reasonings. Look at their past medical reasonings, and apart from their comorbidities, look into all of those things. Is there any red flag, something you need to be careful from there? Look into that. And again, consider their balance. You don't want them to fall. Consider their balance. Consider their age. In fact, when you say, if there is one thing I'm going to tell somebody today is, when you see an amputee patient, don't ever think about standing and walking or open. Don't ever think about, now, you now need to now see that, oh, is it vascular patient am I dealing with, or is it orthopedic? Why do they have that amputation in the, if it is vascular, no to open. If it is orthopedic, now factor in some other things, if that makes sense to somebody. All right, so and again, one thing from real point of view, if you have worked in orthopedic amputee rehabilitation rehab center before, you can also testify to this. Lot of patients with hypocrutches or frame or whatever they are using to operate for amputee for trauma patients, what you also find is by the time you now start, you progress them to prosthetic, to getting to prosthetic fitting and everything. A lot of them also struggle with midline alignment. I think this is commonsensical things. Somebody have been hopping around with one leg for a while now, for almost a year, 2 years, for instance. Now you now progress them, you now start thinking about giving them leg. A lot of people struggle with midline shift. It's also going to impact on their prosthetic usage, on their gait educations, on their gait training, rather, if that makes sense. Another thing, what I've also seen in the past is people with above knee amputations. In fact, when it comes to the way they hope, like they even hope very, very fast compared to people with below knee, because of a lot of reasons as well. Now, people with above knee, like the speed they used to hope is much more than that of the below knee. Now, if you now want to start giving them fitting leg for them, they are also likely to struggle when it comes to like pacing with that prosthetic. Some people also struggle. Some people also struggle again because when it comes to, I'm still coming to phantom pain, sensations, proprioceptive changes, and there are some cortical reorganization, cortical markings, and into all of this, the neuroplasticity and everything into all of these things. If that makes sense to somebody. Let me quickly get a response. Please, does this make sense? What do we think? Do we have contrary things to read? Do we have questions here? Because this part is really, really very important. Yeah, what about amputations due to cancer? Where will you clarify this? Great question. Yeah, I love that. Thank you very much for that. Now, for cancer patients, again, let's think about these things. For somebody to have lost their leg because of cancer in the first place, because of tumor in the first place, think about it. If you give them frame, they start opening around, think about it. These people are likely to fall. Somebody with cancer, it could mean that now maybe a lot of things have been impacted, maybe nutrition-wise. A lot of people, even their nutrition even their weight. Some people might have lost weight. Some people might, their nutrition might have been compromised. Some people might even struggle with sensation as well. Some people, think about all of these things. Think about all of these things. So now look at the risk. Look at the risk associated. So the risk, I will say, is much more. I know, frame will give them a bit of independence, but think about the risk. What will happen potentially if these people end up falling? What will happen potentially? They might also lose the other leg. They might end up on orthopedic bed, hip replacement, this and that, knee replacement, this and that. Think about all of these things. So for cancer patients, for people that are losing their leg, in fact, what guidelines say generally is either you are sarcoma, cancer, blah, 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 those things is no OP. But for traumatic patients, that are young, good balance, good upper body strength, good safety awareness, all of this, you can still try them to, but consider what happens if you now progress them to prosthetic rehabilitations. What will happen? In terms of midlife shifting, in terms of gait educations and all of these things. Think about those things, if that makes sense. Can I get a few more questions or clarification or anything? Or does it make sense? Can we continue? Please, response, please, guys. I have important things to discuss. Hello? Hello?
We can continue, sir.
All right, thank you very much. Yes, thank you. Great stuff. Let's continue. So transfer method, like I mentioned, now we understood vascular patient, no hopping, no walking, no jogging. No frame, no standing aids. So now, what are the transfer method? So this is pivot transfer. If your patient can do it, I just got all of these things online. So this is banana board transfer. And sometimes on the banana board, your patient, of course, day 1, day 2, they might not be as strong as these people here, but just to show us some of these things. So this is banana board. So sometimes you might have on the banana board something that can reduce the frictions. You can maybe pop a sheet, slide sheet or something to make it more easy for your patient transfer. So of course, hoist transfer is also there. Sometimes for bilateral amputees, some people, depending on their upper body strength, some people can do front to back transfer. Some people can, yeah, they can also still do they can also still do banana board as well. No, doing pivoting or low lateral. So, yeah, depending on their upper body strength. Yeah, some people might find it very difficult because, of course, they've lost the 2 leg. But generally, what is much more preferable is they can do front to back transfer, can go with banana board. Now, if I may ask you a question here, this is a rehabilitation question now. Let me quickly read the tab box. Okay. Are they at risk of postural hypotension? Yeah, thank you. Good questions. Of course, every postural patient, again, the first thing, every postural patient is at risk of postural hypotension. Why? They might have lost blood, they've had an anesthetic agent. Yeah, they're at risk. Now, vascular patient, major amputation, they have lost the leg. Don't remember, let's say they have lost the leg to hip disarticulation, or let's say above knee amputation, they have lost a major artery in their body. They have lost their femoral artery. What happens? They have lost femoral artery, they have lost a whole lot of blood. Even when it comes to the blood, what do you call it now? The blood volume. Their blood volume changes. It changes compared to normal person. Don't forget, bloods are making the blood in the bone marrow. Now, somebody have lost one of his bone marrow to amputation. Somebody have lost a major arteries. They are prone to postural hypotension, and that does not still mean by the time you go to their best that all amputations or all amputees should be having postural drop. No, it's individualized to your patient. But great that you've answered this question. Thank you. Your name is not there. This is Samsung. Pretty Samsung. Sorry about that. So good questions. When we go to their bedside, of course, before you do stuff, get their herbs, get their vitals. Very, very important. Thank you. And from clinical reasoning point of view, remember they have lost the whole leg, they have lost femoral artery, they have lost tibial artery, they have lost vertebral artery, their blood volume is likely to change. Some people might be on postural. I think I've had one patient in the past. This patient, his major issue is very cool with the transfer. He's a young guy, but the issue is blood pressure drop, postural drop. Every team, endocrinology will come, this one will come, that one will come. But we just, in the end, we need to go with abdo binders. We just keep it with low lateral. But ideally, this guy should be aiming at high level of prosthetic rehabilitation. But the postural job is just, it's just the issue here. Yeah, another question, in low income settings and you have a patient with below knee ablation due to vascular cause, how do you ambulate them since they can't avoid prosthesis? Yeah. Since they can't avoid prosthesis, and again, we have mentioned that vascular patients, we cannot be opening them around to keep them, have that conversation with them that, yeah, they might likely end up being a wheelchair user. Again, even if they have the money, have we also screened them that they meet the criteria to get leg? That is another thing. We shouldn't be having discussion with leg for everybody. It is not everybody that will meet the criteria. And we have that energy reserved to drive the prosthesis. It's not everybody that will benefit from that leg. But if they will normally benefit from the leg, but there is no resources for them to get the leg. So what do we want to do? Then have that conversation with them that they might need to be in lifelong wheelchair user. Because the risk of giving them frame, the risk of giving them elbow crutches is higher than they having to sit in the wheelchair. If you do risk versus benefit, in the end, if they start opening around, they might end up losing that good leg, and they might end up being a bilateral amputation. They might end up having a bilateral amputation, if that makes sense. Any other question? I'm happy to take questions. I'm happy to take questions here. So like I mentioned, don't forget, yeah, I wanted to ask a question here. Okay, somebody have popped something in again. Let me read before I ask my question. Yeah, I have a question. A 20-year-old girl who had bilateral amputation above and below knee. That's another thing. Thank you very much. I love this. I will still read the rest of the question. You can have somebody bilateral on the right. I'm sorry, you can have somebody below knee on the right, above knee on the left. Yeah, I think this is a case of one. As a result of postpartum palsy, where she had necrotic tissue due to sensory problem, so she has been at home then, developed ischemia and tissue necrotic. Yeah, okay. Let me, I love this question. Go down, please. What's not responding? Yeah. So she had been at home. She has been at home since then. Developed ischemia and tissue necrotic. She has been trained for upper limb and trunk exercises. Okay, keep popping in the question. So why I also the question is not complete yet. So why I want to ask a question here, and my question is this. So if you look at the transfer methods approved here, the hoist, the low lateral, the pivot transfer, the front to back transfer, which do you think, if you need to, let's say your patients now, like they've got little and their upper body strength is not very great, and you are thinking about progressing them, like rehabilitating them from you are thinking about rehabilitating them from low level to high level. So if you need to rank this transfer method, which do you think is the least and which is the highest? If you just pop it your response, or if you want to open your mic, because we also need to understand this. Because it's not all patient. Some patient day one, you go to their bedside, they go upper body strength, they are young, they are able, you just do pivot them out of bed, that's fine. And some patient, it could be an elderly lady, 79-year-old lady, limited mobility. Now they've chopped her leg, and you go to their bedside, and they are struggling. They are unable to do pivot. So how do you, what are you thinking? And of course, they still got some upper body strength. Yeah, they still got some. So how are you planning to progress her? So I need you guys to rank these things from the least to the highest. From the least to the highest. Are we still there, please, guys? Are we still there? We have loads of things to discuss, and time is just running anyhow. All right, yeah. You can open your mic, you can pop your response in the chat box. Thank you, PT Shukro. Thank you. Yeah. Thank you for that. Yeah. Pop your response in the chat box. If you need to rank this transfer method, from the transfer method are low lateral, pivot transfer, banana board transfer, hoist transfer, front to back transfer, whatever. If you need to rank them, which is the least? If you rank them, this, like I need to progress my patient, is it from pivot to low lateral, or low lateral to pivot to banana, or whatever? If you need to rank them, so how will you rank them? I think these are physio stuff. So let's discuss, let's spend time. Yeah. All right. I'm still following up with your questions. Sorry, your name is not there. I'll just say PT iPhone for now. Sorry about that. So yeah, responses, guys. Response, guys. Yeah, what do we think? What do we think? So while I'm awaiting your response, let's take PT iPhone question. So the question is, there is a 20-year-old lady. She's got bilateral arm, one above, one below. She's postpartum palsy. She's got necrotic tissues due to sensory problem, and she has been at home, then developed ischemia and tissue necrosis. She has been trained for she has been trained for upper limb and trunk exercises. She is strong. She's hoping to get prosthetic leg. Is that possible, sir? Yeah. Now, the question here is, look at the age of this young lady. The age is 20 years. And again, the age is 20 years. She's got sensory issues. She's got good upper body strength. She's motivated. She wants to get a leg. Great. Factor in the sensory difficulties. In terms of proprioceptions, by the time we pop, like we do the casting and everything, you pop the leg and everything, will he be able to feel the leg? Think about that. If somebody have got normal, just think about this. If I've got two legs. If I'm struggling with sensation in my leg, is that not going to impact on my balance? Think about those things. Is that not going to impact heavily on my balance? Is that not going to impact on my gait? Like, is that not going to impact on my gait pattern, gait parameters? You can find some people, let's say for instance, it's just unilateral sensory issues. You might find people doing high stepping gait because they cannot properly feel their foot on the floor because they are struggling with proprioception and all of those things. Now, in our own case, it's not limb. The remaining storm now, as it got good sensory changes, is able to feel well. Now, in terms of energy level, above knee on one side, below knee on one side, do you think, yes, he's young. Yeah, great, he's young. Do we think he's got really good reserve to drive that prosthesis? Because on the let's say for instance, on the above knee part, for somebody to drive it above knee part, we should be expecting at least in terms of energy expenditure, it might be between 60 to 80% to drive that. If it is unilateral, like if a patient have got unilateral, let's say above knee amputation, you might, in terms of energy requirement, it might take about 60 to 80% energy requirement to drive that. If it is below knee, it might take maybe around 40 to 60% energy to drive that. Now that somebody have got unilateral amputation, so the energy requirement is now doubled. It might be around 100, 150, 200 to drive both prostheses. So in terms of rehabilitation, in terms of gait pattern, the sensory changes, the energy requirement, the two issue with issues with bilateral amputations might likely lower the chance of this lady. Yeah, that is what I would say. Now, this guy is ischemic again. Ischemic again. Think about these things. We are trying to break this thing down. In terms of ischemia, like that means there is a poor vascular support. Like there is a poor blood supply to that leg. So if you now, for instance, now if you do the casting of, you start popping prosthetic limb, you start fitting limb to that leg. Is that not going to also further compress the vessels in that leg? Is that not going to make the tissue dead? Is that not going to improve? Is that not going to make it worse? Think about those things. So now, yeah, she might have a good body strength, she might be young, she might be fine, but her comorbidities, she's got tissue necrosis. That might also lower a chance of trying now to go in the lane of getting a prosthetic leg, like functional prosthetic leg, to be able to walk around and all of those things. It might really lower her, and even her two limb loss as well. So the chance is low. I would say that chance is low because of that. So that's it. So okay, yeah, I think there is a follow-up question here. I have 20 Obala. Yeah, I think it's the same thing. For now, our sensation is intact. Yeah, if the sensation is intact, also I also advise that you also speak with the vascular team, get the opinion of the vascular team regarding vascular supply, because one of those reasons I'll still discuss in this slide. One of those reasons why you don't want to maybe start thinking about taking your patient through casting and all of those things is vascular supply. If your patient has got ischemic pain, poor blood supply to that storm, you don't want to further put something that will further compress their vessels, if that makes sense. So what I would advise is speak with the medical team, let them come around, let them assess the blood supply to their leg. It could be something, maybe they do Doppler or whatever thing they want to use to check for the patency of the blood supply. If it is patent and it's got good sensations, yeah, it is not left to you as a physio to look at, the energy requirement. I might be needing to drive two legs. It might be too heavy. You might struggle with balance. You might struggle. But if you think, she's got good body strength, it might worth trying. Honestly, it might worth trying and see how she's able to cope. But if the vascular supply is too poor, then guys, it's going to be no to this lady. Thank you. All right. So in terms of ranking, I would say the least, of course, to be your hoist, because hoist is the passive transfer. You just lift somebody up from the bed and pop them wherever you want to pop them. That's the least. Followed by the banana board. Banana board is just to bridge the gap between the bed and the other surface. So banana board, they will just get them to shuffle across the board to get them to the wheelchair. They can use their upper body strength to push up with that. And again, from there, you can low lateral is another one. Low lateral is just, they are not coming into that half stand position. They are still doing sitting. They are just sitting. They are just shoveling across from the bed to the wheelchair and all of these things. The pivot will be the highest, if that makes sense. So you are going from the lift. There are some patients you need to go from the lift to the top, and some patients just pick them from the top, and that's it. If that makes sense to somebody. Let me read the chat box again. If there's any other questions. No. Thanks a lot, sir. Thank you, Peter iPhone. Thank you. Sorry. If you put your name there, please. Thank you very much for that. All right, let's go on because of time. So in terms of hoisting our patient, like I mentioned the other time, there are options. So this is a standard hoist link. You can also use this hoist link for every other patient. I just need to tell us this. But if you need to hoist them, you need to cradle hoist them. I don't know how best to explain this thing right now, honestly. You need to, what cradle hoisting means is, just unlike normal patients, you are bringing this link between their leg. But in their own case, you pass it across. I don't know how best to. I hope we can just have practical sections and we can show ourselves some of these things. But generally speaking, there is a standard hoist link for an amputee patient. So that is called AMOC. That's AMOC. I've written it. That is written here. That's the standard one for them. Don't forget manual lifting patient, like lifting up patient from the bed, like manually. We are not laborat. It's not generally it's not something that is recommended, honestly. So phantom pain sensations is also another issue patient might struggle with at bed. And I must say that in terms of pain is it should be like pain management should be individualized to our patient, because the threshold, pain feelings and everything, it varies from person to person. And like about 80% of amputee patients, usually first week, and even beyond first week, 6 months, 12 months, you can still see some patients, even though the intensity might have gone down, you might still see some patients struggling with pain as well. So and again, let me say this is real, and we also need to have that conversation with patients. Why did I say it is real? Because so most of the time, when you listen to patients, even family members might start thinking, have they lost their mind, or what is going on? Because I have seen patients before that have mentioned to me that they only feel pain, terrible pain, anytime, let's say, they need to pee, or anytime they go to the toilet, or anytime they go to the bathroom, or anytime if their bladder is full, or they are feeling constipated. But to the family members, they feel like, is this, hey, what is going on? Are they start losing their mind, or there is external forces attached to this thing or something like that? No, it is phantom. It is phantom sensation. There are reasons for that. I'm coming back to that. There are reasons, or let me just tell. The reason for that is, if you look at the picture here, this is the picture of the brain. This is homunculus here. Homunculus is just our body representation in the brain. You can see the hand, the head, and everything here. So now, if somebody have their leg being chopped off here, other region of the body will just find a way to migrate to that part. Like the genital area will find a way to migrate to that part. In that, my patient that mentioned to me that they are feeling sensations in their leg, pain, terrible pain when they go to their toilet, because of that, what do you call it, cortical reorganizations. The genital area have actually migrated there, to fill in the gap, chop area in their brain. All right. So what do you want to say to them? You want to reassure them? You want to explore? Reassure them, get them to get used to it, explore some little things you can do with them. And again, let me say this. It is not in every cases that you can manage. It is not in every cases that you can find situation. But even if you don't have anything, reassurance really go a long way. Explain, provide explanation, reasonable explanation in the language patient can understand. Provide it to their family members. Because sometimes you find people attaching different rationale, different things to these things, but because you can, I have also, if you work on vascular, if you are amputee, we are very familiar with amputee, you will testify to this. Some patient can go to their bedside, and let's say you are trying to do your pivot transfer. Some people they are even sitting at your bed. They might start telling you that one of their leg is still on the bed. To you, it might look like they're crazy. For what? For to the family members, they might, what is going on? Why is this patient, since this man since he has had the operation, he has been saying unrealistic? No, they are not running mad. They are not running mad. There are some concepts called telescoping. You can put it on your phone. Telescoping effect. We also got another one called my brain. Freezing. freezing limb, frozen limb, not freezing, frozen limb. So telescoping effect is just like, let somebody have had their limb, they've had the below knee amputation. They might start telling you that something, one of their toes, I think I've got the picture here. Let me show you guys once and for all. Yeah, if you look at this picture here, so what telescoping means is somebody can start telling you that their toes is attached to their stump, or their or their stump. Some people might even tell you their stump has proximally migrated, like they have moved up. It becomes strinkled, something like that. Some people might also tell you that their distal part of the stump has been removed. These are not unrealistic things. This is brain issue. This is physio. We need to understand. If you don't know, and family or patient is telling you, how will you convince them? What do you want to say to them? You want to also start thinking otherwise? No. So we need to be aware of these things. And for a patient, they are telling you, they are sitting and they are saying that their leg is still on the bed. This is also brain work, brain issue. Phantom. So what do you want to? This is frozen limbs. Or their patient can tell you that their leg is just there. They cannot move it. That is their own issue. So we need to be aware of these things. I'm rushing now because of time. Sorry about that. So little things, phantom sensations. What do you want to do with the patient? I will explain the sensitization, getting them this is new baby. Get them to look at it, get them to touch it, use different surfaces. Patient, it's just like try and error. Patient can try different things and they might be comfortable with any of them. Now, stringer therapy, yes, this one is also very important. But stringer therapy sometimes can also be stringer shock can also be used to control edema. But why we say if your patient is not going to get leg, there is no point. Stringer therapy is not just it can work for pain, it can work for edema, it can work for to control the shape of the stump. That's another thing. If you are thinking that your patient is going to get leg, are you also looking at the shape of the stump? And maybe that might be the question for also Mr. iPhone as well. Look at that stump. Is it well aligned, or look at it? Is there any contractor? If suppose it is any contractor, I think around 20, if it's more than 20 degrees or something like that, prosthetic is not going to fit in. Think about all of these things. But if your patient is not going in the lane of getting leg, you might consider some other options. Maybe without needing stringer therapy, I consider another option for them. Distraction is also another thing. Yeah, pain has different layers. Multiple things work for multiple patients. It is not in every pain that your TENS machine, your cryo will work for every patient. That is why we need good understanding about pain. Because again, for pain, their emotions, if they are struggling with acceptance, if they are struggling with if they are very anxious, all of these things will make their pain worse. If they are feeling neglected, their family members is not, this thing will make their painful experience, painful sensation worse. Have you had that conversation? Have you tried to explore why they are in this severe pain? It is not in every issues of pain that they are pregabalin or gabapentin thing that the medical team will prescribe will work. We work well, and it is not in every pain again that your desensitization, your rehab, your exercises, your cardio, and everything will work. Could be maybe just have that conversation with them. It could be reassurance. It could be encouragement. It could be listen to them. Just listen. In fact, delete whatever pain management this thing you have in your mind. Delete it first and listen to them as human. First of all, don't think as a physio. First of all, think as human. That's the way I think. And this go again to every of your back pain patients, knee pain or anything. Don't first think about your equipment first. Think about, have that conversation. This is how great clinicians think. Because they might not even be needing your TENS. They might not even need your infrared. So that is why some people will say pain is complex and it has multiple layers. You need to explore those layers before you arrive at whatever things you want to do. Yeah, I understand our people, they want to be touched, they want cryo, but we are not technicians. We are clinicians. Our clinical reasonings must dictate whatever we'll be doing with our patients. If that makes sense, let's crack on. Exercises help. Tell them, you've been in bed 2 days, 3 days, you've not been out of bed. Let's try moving this storm. Let's do some exercises. Let's get you out. Changing positions. We get them to do around all these things with their painful experience. Acupuncture. Yeah, some researches I just pop it there. Some researches also show that acupuncture can also help. Yeah, your TENS will also help. Co-modality, heat modalities, all those things can help. We know all of the graded motor image. I could have loved to spend good time. Yeah, I love this thing, but maybe later on, but it's going to take my lot of time. But I won't do that. But I could have loved to talk you guys through that one. I really love it. Very, very, very interesting, but we won't be able to explore that today, unfortunately. Let me quickly read the chat box before we continue. Yeah, Peter iPhone, thank you very much. Dr. Ganiyu Abiodun. Oh, yeah, Dr. Ganiyu Abiodun. Is that the man with the yeah? Oh, yeah. So Dr. iPhone is now struggling. God, Sulatu Yusuf. I would say PT Yusuf. Thank you very much. I really enjoyed that clinical scenario you brought. I love clinical stuff. Thank you very much. Yeah, I acknowledge everyone, Dr. Israel and every other. Yeah, Dr. PT Kaliva has written, I hope MRTB and NSP representative are in this discussion room. You will see a lot of senior colleagues confining junior physio to the risk of their health by doing manual laborers on the ward. Yeah, this is honestly, when I was talking about manual handling that time, I really talk about these things. We need, in fact, we need to be championing this thing, not just physio, even medical team. You see people, how do they, have we ever thought about this thing? How patients are being moved from their surgical bed to the bed? How did they transfer them? Let's think about this thing. This is our domain. We can champion discussion manual handling. There could be regulation. We need MRTB, we need NSP or whatever association you are to. We need those equipment. We need that regulation. We need that standard. This is 2026, and we need to be thinking high. We are not laborers, honestly. All right, let's move forward. Thank you for that, PT Kaliva. All right. So the other thing here is phantom limb pain assessment. Just like every pain, you're going to do location of pain, their onset, their characteristics, what affect the pain, what make it worse. You do compare. See, that is why I said listen to them first. Don't think as a physio, first of all. Explore their mind. What do they think is going on? What are their concerns? What are their expectations? Then begin your pain assessment, your LOSIDA, whatever this thing you use. You begin that, ask them the time of the day, what. Again, check their past medical history or ask them, why did they have the amputation in the first place? If somebody is having very, very serious infection in the wound, it's going to worsen their pain. Think about that. Pain medications, are there? Everything pain is not physio. Pain management is MDT work. Acutely, if you are seeing patient in the hospital, they want post-op, they're having a very severe pain. Do you think about TENS first? Do you think about cryo? And again, be careful with cryo sometimes, acutely. For patients with vascular patients, cryo might be a contraindication to those cryo or cryo, especially cryo in acute hospital. Think about those things. Vascular patients, that might compromise their vessel. Think about that. And again, pain management, you of course get them pain medication, pregabalin, carbachentine, whatever things you want to get to them, give it to them. And again, relate that pain with their mental aspect of it, like psychology. How does that impact them? Does it make them moody? Does it make them sleepy on the world? Are they struggling? Think about those things. It's not just pain. You are thinking holistically. That is how clinicians think. You are thinking holistically. And again, previous treatment. Look at their previous. If we are saying them, let's say outpatients now, not even acute hospital now. What have they tried in the past? How have they been able to manage the pain? Patients, they know best. You can still explore what some of those things they've done in the past. Yeah, and you can modify as well. Pain rating, all those things, weather conditions, during the heat weather. Yeah, of course, pain can also fluctuate. And again, also ask them that question I mentioned. Remember that my patient, is there any pain when they go to the bathroom, when they are constipated, when they are trying to open their bowels, they are trying to do number one, number two? Ask them those questions. Doing sexual activities. Is there any pain? This go back to your cortical organization. Remember your neuroplasticity kind of things. Now, in terms of objective assessment, there's no time to explain. Oh, I'm just sorry. So think about the condition of the stone. Think about scar. Is there infection? Is there any discharge pulse and all of those things? You can do thinner tests. Is there any pressure area, pressure point? Telescoping effect, frozen effect. Ask them some of these things. These are things that you will dictate whatever you want to be doing. Don't think about cryo first. Don't think about TENS first. Explore first of all. And again, in terms of MDT, like I mentioned, pharmacology, surgical option is also there. Imagine if somebody have gone a very, very bad wound, is now infected, scarring, is not healing well. Some of them, they might need to return them back to the theater. They might do ablation surgeries, neuroma surgeries. There is nerve regeneration surgery. There are a bunch of them. Think about psychologists. Some pain might really, really very, very terrible that is impacting your patient in terms of the mood. And you can also have patients with poor psychological background like anxiety disorder, bipolar syndrome, and all of those things. Do they need psychologists? Think about that. Prosthetics, you need them. I have had patients in the past that they will tell you anytime if they want to sleep, sometimes they need to don their prosthetic, their limb, because if they don't do that, they're going to be in terrible pain. There are people like that. And there are people, it could be, maybe your prosthetic can design something for them that might not be as heavy or something that will be more comfortable to them. Just that their brain now is now used to that can be comfortable for them to sleep in the bed at night or something. Think about anything. You need them. But if you don't explore, you will know. You won't know what is best for your patient. Other skills, CBT, cognitive behavioral therapy, MI, motivational interviewing, sleeping hygienes, have you explored talking therapy, virtual, there are a lot of them. There are a lot of these things. There are a lot of them. There's no time to break them down, unfortunately. Let's talk about stump management. So stump edema, sorry. And again, stump, when there is a lot of edema, of course, there will be pain, delay wound healing. That will impact on their transfer ability. There can be increased pain. It's going to increase. It's going to worsen their shape and maturation of the stump. And again, in terms of prosthetic limb, if we are thinking if they are able, like ideally they should be getting leg, it's also going to impact them as well. All right, so stump edema. So this is the shrinkers. Some people, you can have 2B grip, you can have pseudo socks, depending on where you work. But like I mentioned the other time, if your patient is if it is unlikely for your patient to get a leg, there might not be need to be doing all of these things. And again, let me also say this. I remember, please, evidence-based wise. I know we do it. We do this figure 8, bandaging and these things. What is the evidence for those things? What is the evidence? And again, people just do it, they just do it, blah, 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 blah. They don't even consider the pressure area, the pressure redistribution of that bandage. They don't even consider, they just do it and just, we need clinical reasoning for it. This is vascular patients. If you just do the compression anyhow, that might also compromise the blood supply to that leg. For somebody to have lost that leg in the first place, there might be a serious vascular issue. Now that you are now compressing anyhow with your bandage, figure 8 or whatever thing you are doing, honestly speaking, you might worse. In fact, and again, let me say this: there is also chance for somebody that have had below knee to also have above knee, to even lose the whole leg, to even go as high as hip disarticulations. We need to help them manage the rest of the stump, like the remaining leg they've got. If care is not taken, some patient might also end up, because of bandaging, you are compromising the vessel. Before you know, ischemic changes, poor blood supply, serious pain, and the surgeon will just come and say, this wound is not healing well, or it's not this, not that. They need to go higher up. You can say, okay, some of us might not even know that is what has even caused their problem. Not even patient issues now, it is now clinician poor knowledge that has led to that. So evidence-based wise, we want something that can equally distribute the pressure. These are some of these things evidences have recommended. Let's try to do the best for our patient. I won't take this now, the measurement and everything. I won't do that because of time. And of course, it's practical related anyway. So for shrinkers, just a rough guide. Day 1, if they are able, they can do 4 hours, they can do 8 hours, day 2, day 3. You can do it half a day. And again, before you start applying shrinker, take their measurement. What is the baseline measurement you are working with? Then after day 1, day 2, you keep tracking with measurements, and like that. That makes sense. So, and it varies from patient. It could be some people they do 3 hours, they do 20 minutes, half an hour. They're able to tolerate. They're not able to tolerate. Then progress from there. And contraindication, like I mentioned, before you start compressing someone's leg, even with bandage that we use, do we consider the vascular supply to that leg? Do we consider if the patient is having unbearable? I know some patients, by the time you even put the stringer and everything, you might help with the pain and everything. But when you put the stringer and it becomes more painful, do you still want to keep it? And you keep your patient, Baba, Emma Paramonio, you have to bear the pain, no pain, no gain. What are you doing? You are a poor clinician. There should be other things you can explore for your patient. You are a poor clinician. There's nothing like no pain, no gain. What are you doing? We shouldn't be causing more harm for patients. Yeah, I understand sometimes we need to do risk versus benefit kind of thing, but it's not in this situation. Honestly. All right, so contraindication to that might be pain, sensation, DVT, ischemia, and all of those things. So, all right, let's take another one. Yeah, so here, so wound care. And again, physio, we also need to be aware about wounds. Let's say I want to apply string canal to the stump. It is my responsibility. I've got duty of care to that patient to first of all check their wound. Is there infection ongoing, or is it safe for me to apply that? I need to check. Now, if I just ask question, please, I need response because of time. Look at this first stump here. This first stump, what do we think? Is he healing well? Is he a bad wound? Look at the other ones here. What do we think? Because we need to be able to identify these things. Now, what do we think? Let me use the opportunity to quickly look at the chat box. I value feedback a lot. Thank you for the wonderful explanation. Does it mean that anytime we have patient with amputation due to diabetes of the diabetes, we should forget things about walking? Yeah, it depends. For like if you need to think about walking, then they need to be getting leg. They need to be getting leg. But if they are not getting leg and they've lost their limb because of diabetes, because of anything vascular related, you shouldn't be, and they are not getting leg, you shouldn't be talking about. You shouldn't be talking anything working with them. Just find a way to discuss with them that they are likely to end up being what is it? They're likely to end up being what is it now? Transfer wheelchair users as opposed to open around, because the chance is they might likely end up losing the other leg. So at this time, please talk about acupuncture. Oh, there's no time to discuss. Unfortunately, it's going to take time. I'm sorry. The patient has no pain, no sensation. The limbs are cortical shape, everything intact, but I'm just skeptical about the mind alignment. As you said, yes, that is the issue. It requires more bilateral amputee. Yeah. Mind alignment, energy issue, energy to drive the pain. Patient has no pain, no sensation, the limb, cortical shape. Yeah. Thank you. Now, the first one, let me just take this in straight away. This thing, I know the first one, this is a poor, this is a good wound. How do I know good wounds? You need to look at the fact, the color. This is pink. This is pink supply. This is pink, which shows that what's it called now? The blood supply is good. And again, this is an open wound. This is an open wound. Yeah, that's why we might be thinking, this is a poor blood supply. Keep up your response. Now look at the second one. This second one here is looking fresh. It's looking fresh and just black this thing. Yeah, you might think that this is a great one, but unfortunately, I'm sorry. If you look at this dark stuff, this is what do we call it? Escar. If you put that on your Google, it's going to bring something. This is a dead cell. Yeah, on top of this one. Yeah, of course, other parts are healing well, but this region here, this region here is not healing well. So this region need to be removed. The nursing staff or the medical team, they need to remove these things to see what is underneath. Sometimes when they check underneath, they might find yellowish color kind of things. These are signs of, ideally, good healing should be pink or something like that, that shows like blood is flowing there. So those things need to be removed, because the healing needs to happen inside, outside, like from inside down to outside, not from the other way around, if that makes sense. But to patient, I swear, to patient, these are things that also need to be, because to patient that has this kind of wound in the front, they might say, my wound is healing well, the other part is great, I don't have problem with it. But they also need to explain to them that, this thing needs to be removed, and it does not mean like now we are taking you back again. No, that does not mean that. So, I'll just take this last one. Of course, this one is great. The incision is there. This other one is also there. This last one here. What is this big bunch something here? What is this? This is hematoma. This thing needs to be evacuated, either by aspiration or surgical procedure. This is a sign that this is not great at that moment. If that makes sense, we need to be able to identify wounds. Look at the wound, and again, for instance, now this hematoma. Now I cannot go there and start bandaging and say, what am I doing? What am I doing? So all of these things we need to really understand. I don't really have time to discuss for that, but PAM 8, I won't go through this because of time. PAM 8, and again, before you start thinking about getting somebody's leg, and again, let me say this: For palm aid, if your patient is it's very unlikely that they will get leg. There might not be need for us to be palming these patients. There might not be need. Just keep them on transfer, do exercises, get them to mobilize, get them to self-propel wheelchair around, get them to do it on different surfaces, get them to strengthen their upper body, get them to do some cardio rehab, their upper body, all those things to increase their endurance and anything. So there might not be need to be trying all of this. But if they are going in the lane of getting a leg, yeah, we can start palming them maybe by day 7. The pressure is there and everything. There's no time to explain this thing. I'm sorry. So I will just take the remaining part. I'm jumping some slide now. Fall is also another thing you need to be thinking for your patient. Fall. For vascular patient, as much as you can, you don't want them to be falling, because if they fall, they might have another wound. The wound might also struggle to heal up. And if it doesn't heal up, unfortunately, if that is on that leg, on the other leg, on the other good leg, if that wound keep breaking down, get infected and everything, then also that leg. Again, somebody can have a fall, head injury, fracture bone, this and that. It's not something we want. So also have that discussion with them when they, let's say by chance, your patient have a fall. Even if they are wheelchair transfer, they can have a fall, maybe because they didn't remove their armrest or their foot plate, or maybe they didn't position their wheelchair properly, and now they have a fall. So how do you get up? You also need to have, sometimes what we do, sometimes if your patient is able, to get them to sit in the floor, let them practice that backward chaining to floor transfer, to be able to transfer from the floor to the wheelchair. You can teach your patient if they are able. Not more patient. If you get a patient that maybe is always transferred to the wheelchair, you now put them on the floor. I'm sorry, you'll be the one that will finally pick them up back to the wheelchair. Think about their functional level again for you to get patient from the, for patient to be able to get from the floor to the wheelchair. But if they are able, they are doing pivoting transfer with the armrest intact without even removing the armrest. Yeah, you can try them, floor transfer, backward training, but all those things. So these are practical things anyways, but hopefully maybe later God will help us, we can have some practical sessions. So OT domains, our OT is not physio stuff, and it's not OT alone. PT should be working with MDT, doctors, nurses, vascular team, psychologists, everybody, prosthetists. Then OT also help in the cognitive assessment. Let's say, for instance, you do your 480 post-op, your patient is now confused. Have you involved your OT colleagues? Have they gone to the patient bedside to progress their cognition? There are some advanced cognitive tools that OT can do with this patient. They can try MOCA, they can try mini haze. Even what nice guidelines recommended is, even if your patient is not cognitive like day 1 or prior to surgery, you should complete mini haze with them. Mini haze will just also further check their cognition, all of those things. Home assessment, equipment, what equipment will they be needing? If somebody is doing transfer, and do they need commode? Do they need equipment? Like I mentioned the other time, the height of the toilet is 16 inches. The wheelchair is 18 inches. Let's say somebody is now struggling to transfer from the toilet to the wheelchair. What equipment can we give? Stable, very stable equipment. We can give them more brain. I think we have done that before in some of our teaching. More brain. You can give them more brain. More brain is just something that will raise the seat and it has handle on the other side. Why more brain? Why not raise toilet seat? Why not, what's the other one? Freestanding toilet frame. Because more brain is stable. Remember, somebody has one leg, stability. You need something that is very stable. Clinical reasoning. There's nothing in physio that you shouldn't be reasoning, like you should not provide good clinical reasoning for. And all these things should go into your notes. If I'm giving, I will say, oh yeah, this is the reason why I'm doing this, not the other ones. That's it. All right. So access visit, they can go to their property, look at their home environment. What do they need to modify? Do they need carpenter to do something? Do they need bricklayer? Think about all of those things. So our functional assessment, OT can also try to do some kitchen assessment with them. Unfortunately, God will help us. Kitchen assessment, toilet, even as far as doing shopping with patients, teach them how to shop in their wheelchair. So it's sweet, but we need our government and everyone to just, God will help us. But as PT, even OT, like PT, OT stuff, you can practice different surface transfer from bed to chair to wheelchair, chair to commode, to toilet. Even before we leave hospital, these are something we should be checking ideally, because we know these people are going home. How will they use the toilet? Have you done toilet transfer with them? How will they transfer from the bed to their chair? Have you done chair transfer with them? All these things we need to check. We need to check before we discharge them, before we leave them. It's a big change, big change. When we say rehabilitation is something, it's just integrating your patient back, settle them, give them. In fact, the first question I asked the other time about what is your major goal? Your major goal should be get your patient to be independent as much as they can. That is your major goal for this patient. All right. So, all right. Now, another thing about stairs, there are a lot of questions about stair management. Somebody that got stairs at home, yeah, this is when again you need your clinical reasoning. Remember, no hoping. So, if you are saying no hoping, how will somebody now go on the stairs? The guidelines, the national guideline, the recommendation is they go on their bum. They go on their bum. They go on their bum. They go on bottom on the stairs. And again, clinical reasoning wise, do you now think it is all patients that can go on their bottom, that will be able to go from one step to another, that will have the endurance, that will be able at the top landing of the stairs, at the top landing, that will be able to now sit to stand from that top landing to the wheelchair, whatever thing they want to be using upstairs. And again, think about it. If the patient is able to do the stairs, they will need one equipment downstairs. They will need one equipment at the bottom landing, and they also need one mobility equipment at the top landing. Is somebody factoring this thing? Can we get this thing? If this is the stairs now, let's say my patients now, they meet the criteria, they've done stair assessment with me on bottom, they're able to stand. Of course, we do it here. Patients are fine. They go on their bottom. But think about they will need mobility equipment upstairs. They will need mobility equipment downstairs. Because you cannot go on the wheelchair. You cannot use wheelchair. Or if they've got a family member, they can help them to know. But think about their own safety too. Think about their own safety too. Think about their own safety. So it could be maybe what we do here is we can give somebody wheel commodes to use upstairs. Their wheelchair will be downstairs. They can use their wheelchair, outdoor mobility and everything like that. So, and again, when it comes to, before I forget, about the criteria for stairs, before you are thinking about patient going on stairs, you need to think about they need good upper body strength, they need good range of motion in the other good leg. These are clinical physio stuff. They need good range of motion in the other good leg. Think about those things. Not every random patient. Somebody struggling to do lateral pivot transfer and you want to carry them to the stairs. What are you doing? Somebody just transfer from bed to wheelchair, they are out of bed. You want to carry them to the stairs. You can't do 12 staircase. What are you doing? So think about those things. Think about those. And again, if they cannot manage stairs, let's say they live upstairs, have that discussion with them to now be living downstairs. It's as simple as that. It's as simple as that. So because don't forget, your goal is get people to be independent as much as they are. If that makes sense to somebody. So that's that. And again, another thing here is in Nigeria, the chances people will likely be restricted at home. They won't be able to go to work. They won't be able to go to mosque. They won't be able to go. This is an unfortunate situation we find ourselves. Look at our road construction. Even look at our big city in Nigeria. The roads are not wheelchair accessible. These are very bad. These are what we need. I don't know. Maybe we can have NGOs, advocate, even our government. Look at the road. Look at our places. Our places in what is it? Look at our public places. They are not wheelchair accessible. Here in the West, you will find everywhere is wheelchair accessible. Even most patients, and again, these are part of the reasons our people, even most time, by the time they tell them that they're going to chop their leg, most people will leave the hospital because they know that is the end of them. But here, by the time they tell them they will chop, most people will not even be faced, they will not even be concerned because they know they're on their wheelchair. They can go anywhere. They can go anywhere. They can do anything on their wheelchair. You find people going on the road with their mobility scooter, electric wheelchair, no concern. There is motorway, there is wheelchair, everything is well. So we need to within our limits, this is just not the MRTB, not NSP or this thing alone. This is everyone's business. We need to find a way to get our government to do the right thing. Honestly, look at even big cities. By the time I look at the big cities, so so where is the inclusions? Where is the inclusions? So we need to be thinking of, so these are part of physio stuff, physio OT stuff, therapy stuff, rehabilitations. All right, God will help us. All right, equipment wise, so and again, somebody that is likely to end up as a long-term wheelchair user, think about pressure sore. Do they have cushion on their wheelchair? And if somebody is bilateral harm, like the case, I've forgotten that name again, the PT brought the other time, they might be needing anti-tipper in their wheelchair for safety reasons. You don't want, because if, let's say you've got a big lady now, for instance, and they've got bilateral harm, the wheelchair is likely to tip backward. Have you spoken to them about anti-tipper, something like that? So think about all of this. I think I've mentioned some of this equipment here. So we won't go back to it. Complications, we won't discuss. Of course, these are physio-related stuff. We are familiar with this one. So prosthetic rehabilitation, unfortunately, we won't be able to take that as well. But I'm going to send the slide to Ross. So in time, but I will speak briefly about this outcome measure. So 480 mini haze, there is brain scores, there is French. Those are the necessary ones you can be doing here. So some other ones that are for prosthetic patients, to check their endurance and all of those things here. But normal, every patient do their 480, like I mentioned. Mini haze, these are OT stuff. French, you can also do French to check for their instrumental activities of daily living. So discharge, think about discharge. This is acute hospital, don't forget. Think about discharge, and before you discharge the patient, at least from compassionate, ensure that they have mobility equipment, they have wheelchair, they can do brief transfer, and arrange follow-up with them. Follow up, like we do community these things at home. Arrange follow-up. Get them to be able to be independent as much as we can. So maybe I will stop here today. I will just take questions. I'm happy to come tomorrow. Tomorrow is like before. Tomorrow was set for another thing, cardiothoracic surgery, but I won't take that tomorrow. Come and complete this slide tomorrow. Then we can do cardiothoracic next time. So I'm going to stop here tomorrow because I like to take these other parts too. Footwear. Let me just show you. I like to talk about this footwear. I like to talk about them, but unfortunately, I won't be able to take. I like to discuss food therapy, but I won't do that today. I'm going to stop here. So let me just take questions because of time. Time has gone. Let me just take questions and we can end the class. Or if you like, if you have anything you like to share in particular, because we all need to be very, very passionate about this domain. Because chopping someone's leg is as equivalent as you have ended their life in Nigeria. That is what it means. It's as equivalent as people have ended their life. You have rendered them redundant. You have rendered them redundant. It is only rehabilitations. And when I say rehabilitation does not mean it is a must, they must get leg. Rehabilitation does not mean it is a must. It is not everybody that will be getting leg. If that makes sense. Rehabilitation comes across accessibilities to be public faces. They can go to mosque, they can go to church, they can go to one bed, they can go. That is rehabilitation, getting patients as independent as that, if they are able. Not everybody, again, that will be able to do that, even if places are accessible. That's rehabilitation. Rehabilitation is checking their limitations. How do we help them? Who do we need? And when we say rehabilitation again, it's not just physio. That is another problem, another issues we have in Nigeria. When people say rehabilitation, it's just physio. We can have nurses coming to help us in some area. We can have doctors coming to help us in our rehabilitation. Imagine somebody having infection in the discharge and everything, and they are in serious, severe pain. That is no more physio domain. Doctor, let them look at it. Because the goal at the end of the day is getting this patient to be independent as much as they can. And again, it's not all patients. Let's clarify. It's not all patients that will be very independent. Some might end up as bedbound. But if they are bedbound, have you had a look? What do we have to do? Do they have pressure relieving agents? Have you taught the family how to roll side to side? Have you taught them how to roll side to side? Like to shift pressure to prevent skin damage and all of those things? Have you taught them some breathing exercises they can be doing to prevent, just to manage their chest? Those kind of things. And again, another problem we also have from physio point of view again, remove the financial aspect of it, like the PP that we do, remove the financial aspect of it. Do we also know when to stop? Like when some patients have reached their potentials, their full rehab potential, do we even know when to stop? That is some of the problem we have. Let me make it clear. If you are seeing a stroke patient, this patient have got spasticity. In most cases, what stopped us from going to their home to do our rehabilitation most time is maybe financial part from the issue of family. It is not all stroke patient again that will regain their arm loss, their loss of arm functions. Do we have some predictive tools? Do we know like some clinical indications? These are clinical reasoning kind of things to know. Yeah. Do we to know when to say, yeah, oh, I think I really have to have that conversation with this my patient. That yeah, I think this is the peak. And meaning this is the peak again does not mean that is the end of everything. You guys, it could be you just teach family, do some maybe preventive therapy to continue on their own, just to prevent contracture, manage swelling edema if it is the case of stroke or something like that. Same thing also happens here. When to stop, when you know when to stop and say, yeah, oh, this is the end of this. This is the peak we can achieve with this amputee because of what they have and their background and everything. So, all right, let's take questions, guys. Questions. If you have any clarification or anything, thank you so much. Thank you. I appreciate that. Thank you, PT. Yeah, question. Because of time, we can come in tomorrow to talk about food therapy. I'm happy to take that tomorrow. I will postpone the cardiothoracic part of it. Question, clarification, additional thing. Are we still here? I'm just speaking. Hello? Hello? Hello, somebody? Hello? All right, people are responding. Oh, yeah, thank you. Yeah, thank you, everyone. I really appreciate, yeah. I really appreciate. I really appreciate our coming and yeah. Thank you. I really appreciate us learning together. Everyone is learning, honestly, and we keep learning. Let's keep improving ourselves. Let's better our practice. Let's get our elders. Let's get them to do some right things. Let's get them to do some needful things. Let's get them to progress our practice. Yeah. Let's get the government. Let's get everyone hands on deck. Yeah. Thank you, everyone. Thank you. So in the absence of questions or contributions or anything, I'd like to stop here today. Thank you so much, everyone. I really appreciate us. Yeah. Oh, somebody asked, Lucy, that's subjective. Yeah. That's location of pain, onset, characteristics, what is it? The duration of pain, aggravating factor, something like that. Yeah. So that's what it means, basically. A lot of them, like, it's just like a mnemonic, it's acronym or something, just to remember some, maybe you, just to remember what you can be asking patient about pain and everything. So that's it. Thank you very much. Thank you. So we catch up tomorrow by grace of God. All right. So enjoy the rest of the day. Thank you.